started, I know some people would ask me questions when you go to the, making it clear, when you go to the training center, if you address the CET items, you have addressed what the paper would have been. So if you just address the CET items, that's all you got to do. Okay? And it's on your CET. Now, something else happened, and you want to express it and let your instructor know about it, sure, just write an additional paragraph or two, really 2 paragraphs. Now, when you're on leadership management, if you're unable to observe a CET item, you need to say, this is what the nurse stated to me that would fit that area. You don't need to make it up, but just say what the nurse would have said to you. And that being said, you know which items are in the leadership management. Ask the nurse. You know, and she can explain it, and you have your write-up on your CET about it. Any questions before we begin? Okay, I know you have a farm test today, and my focus right now is to go over some vascular disorders, and then, and you'll need to pull up, we're not going to go over the whole, definitely 120 slides, but there's some disorders on that PowerPoint, and it's labeled arterial venous disorders. We're going to address a few of those disorders. And it's in black. And it's under current PowerPoint. Okay, of course you know the anatomy of veins and arteries. You know that arterial flow is away from the heart. And the way we know if the arterial flow is optimum, we notice, did the person have any problem with perfusion? That's the oxygenated blood going to the body. And then those were things like start from head to toe. If the person had a problem with arterial flow, they may be anxious, they may be confused if it's a late sign. And the skin, you would have noticed some pallor. And then we went from the body systems, there might be some shortness of breath. And if it's a flow to the kidneys, you might have some urine output decrease. Now venous, we assess that relative to when we started assessing thriving sites. We wanted elasticity versus induration. With venous also, you knew that with elderly, the permeability increases. And then there are some individuals who get certain therapies where they need a larger diameter intima. This is just review. So we're not going to spend a bunch of time on that. Venous thrombosis. Venous thrombosis can be in a peripheral vein. And how would you know someone had a venous thrombosis? How would you know they had a thrombophlebitis? Thriving site. Remember? Red streaking. What would the IV flow be if there's thrombosis? Slow. You're not going to get the rate that you need. However, that is peripheral. When you have one of your major limb veins, like for instance in your legs, if someone had a thrombophlebitis, deep vein thrombosis in those, how might it manifest? What would the patient complain? If they had a large thrombus in the leg. Pain. And there would be asymmetry because the inflammatory response setting in. Okay? Just the difference if it's just a peripheral vein versus a major blood vessel. Okay, we have thrombophlebitis. Sometimes you can have a thrombus and there's not any inflammation, but a lot of the times you will have the inflammation and you know you have it because of the asymmetry, the edema that sets in. Phlebitis we know about. The only difference between thrombophlebitis and phlebitis is the thrombus that's formed is affecting your IV rate of infusion, the amount they get, and also with thrombophlebitis, would it be elastic? Would be almost cord-like, okay? And with deep vein thrombosis, we're going to hit that here. With deep vein thrombosis, who is prone to that?
Anybody got surgery?
Who said it first? What you said?
Anybody got surgery?
Surgery. And what do we give to those people so the thrombus didn't form? Heparin or Lovenox. What did you do with them once the doc gave the go ahead for mobility? You got them up. So there wasn't stasis of blood. Did someone in the second row say something? Immobility is one. And we said someone post-op. Someone who's sedentary, period. Okay. Someone who may travels where you're dependent, your legs are down, you don't have time to exercise those legs. Someone who might have a thrombus form, someone who's dehydrated for an extended length of time. Nurses are culprits for deep vein thrombosis because you don't get enough time to drink. We're not sitting all the time, but we're constantly on our legs. When we do sit down, we want to sit down an extended time, but we can't. And so hydration is an issue with the nurses. And also, like I said, when you do sit down, and a lot of the time, you can have stasis of blood that stays in those, the vasculature. Okay, we kind of went over there. Venous stasis is an issue. Someone who has hypercoagulability disorder. Someone, what did we talk about last week? The disorder where that someone had too much red blood cells. Polycythemia. Injury to venous walls from IV infections, fractures, and post-op patients. Pregnancy because of the volume of blood. You can have the volume, but you still get the anemia because of the plasma. And people who are on oral contraceptives. So, from this, if you had a question that asked you, you have a 26-year-old female. She's admitted to your unit. And she gives you her history of medication she takes. What medication would throw her as a risk? Or, what medication would throw as a risk for thrombophlebitis? You'll have a list of meds, corroborative. Or it could say, of the following, who is at risk? Choose all that apply for thrombosis. Okay, we know about phlebitis. I'm not going to go over that. You know what it is. Then that brings me to, you will need to know relative to IVs for your checkoff, IV checkoff, and just throughout clinical. What are the complications of IV therapy? And we already said phlebitis, thrombophlebitis, infiltration, extravasation, and fluid overload. If you know what fluid overload would manifest, what is it? Edema. What about here? Crackle tube. Who is at risk? What age group?
Elderly.
Elderly. Deep vein thrombosis. person may have to address what the patient may complain of or have symptoms occur. There may be pain in the calf, it can be in the shin, and you look at the legs, there's asymmetry, there's edema. This positive Holman sign, in your book, it should tell you that you should not try to determine a Holman sign. They still do it a lot in OD, obstetrics. But a positive Holman sign, just think, okay, let me ask you first. How do you assess for a positive Holman?
You push their foot back or something.
Tuck their, okay, their foot's like this, what do they need to do? Pump the foot against your hand, and it will elicit a pain in the calf. What are you doing when you're doing that? Yes, a lot of books will tell you that that's not the thing to do because you can then make it immobile. Okay, you will have warm skin because of the inflammatory response that has gone on. You want bed rest because if the person's looking around, of course, they can dislodge by activity supply. Elevate because you want that venous return back to the heart, but you're not hitting them up per se. You want the edema to subside. You don't want the knee gash. Do you know what the knee gash of the bed is? Okay. That's when you raise the foot of the bed, you raise the head of the bed, or that's a way of gashing. Or you put the old beds. A lot of places don't have it. You would raise the foot and just leave the foot. What does that do to the groin area of circulation? Like in a V. And you don't want pooling of blood there because that's going to cause stasis. Do not massage the extremity. I'm going to answer your question. Provide thigh-high compression, which is the TED hose. It's not enough to do the knee-high TED. The anti-embolism stockings. And ask you 2 questions. Okay, you're the nurse, and you have a new grad working with you. You are doing teaching to a patient who's going to be going home. They have recovered from deep vein thrombosis. The new grad says to the patient, when you get home, if you have pain, if you don't always take the pain medication, you can massage that extremity. What is your rationale for not, you know it already. What would you say to the new grad? What's your rationale for not massaging?
Different logic.
Yes. You're causing friction, which increases circulation. You can dislodge that thrombus where it becomes immobilized. And that is something where you predispose that patient to a CVA, an MI, or a lung thrombus. Okay. TED hose. When would you take them off? At night. There's less activity, the patient's resting, and you put them back on. One of my pet peeves is the patient was incontinent, and the TED hose are on, and some nurse doesn't take the time to take them off at night, wash them, or get a new pair. Patients walking around, oh yeah, you're keeping them from venous stasis, but you are not promoting the overall integrity of the patient by having clean TED hose. Okay, why does TED hose have the little hole in the top?
So that you can check for
You can cap refill, and you can put them down and check your pulses. Okay.
Yeah.
Okay. They don't do compresses too much anymore. Okay. You're monitoring the circumference because you're checking for a decrease of edema. So in the AEM, you can have your nurse tech delegate to your nurse tech to do the circumference of the thighs and calves. You want to monitor for shortness of breath and chest pain because if that's occurring, it may be that that person may have a little fragment of fibrin that has been dislodged, or they may have through a clot, which is emboli. Okay. Generally, when you guys have them on med-surg, they started them on heparin. Okay. What lab are we? Is there? What lab are you?
No, PTT.
ETT and H. You can make an H out of T. That heparin. And when they initially come to the hospital, it's heparin IV route. Remember that little heparin drip column that we've done? Or when we run this next test? And so heparin IV. As they're getting ready to go home, what med might be added? Coumadin. So if you have a test question and it says your patient's on Coumadin and they're also on heparin, that's okay. You're measuring two different areas. With the PTT, you're measuring the therapeuticness of heparin, and with the PT-INR, you're checking the therapeuticness of Coumadin because they're going home on Coumadin. Generic name warfarin for Coumadin. And as the DVT is resolving and you're getting ready for a home, that's when you would institute. Okay. What would interfere with the, what foods would interfere with the action of Coumadin?
Green leafy vegetables.
Green leafy vegetables, what you said? Okay, anything with increased K. Vitamin K is synthesized in the liver. Okay. So that being said, that would be something pertinent, and the question might be asked: what would you tell the patient to avoid, or what would the patient choose to eat that would alert you to the fact that you need to do some further teaching? So if this patient says, "Oh, this is time for me to go on a diet. I'm going to start on these salads and everything." Not a good choice. Probably needs it, but that's not the choice that person keep in mind the difference between heparin and TPA is TPA, which is the thrombolytic. It can dissolve a clot. Heparin, Coumadin, it decreases the incidence of clot forming. Oh, we already went over this. Pain management is needed. Sometimes just resting the limbs is the thing. And the person may not even need to take an analgesic per se. Okay, what would be a hazard side effect of Coumadin? If it's antibiotic,
Risk for bleeding.
the adverse would be some degree of bleeding. On the skin, you would see the TPI, you might have the ecchymotic spots, bruising. What might you see about the gums? Bleeding.
Right.
So what would you teach them?
Soft bristle.
Soft bristle. Toothbrush. What would you men in shaving?
Electric razor.
Electric razor. What about, what would you teach someone of childbearing age relative to every month?
To report if they're filling out more pads than normal.
Yes, because it affects the flow. Okay. Lower extremity edema, if the edema is there and you want to bring it down, there may be a diuretic, which is one that you know that Lasix is potassium
Wasting.
So what would you teach your patient if they're going to do Lasix? Potato, okay, all the above.
Would you
Huh?
have someone long term on a diuretic though?
Not long term, but say initially.
Initially? Okay.
But, let's see, this DVT patient also has hypertension, they may have like a hydrochlorothiazide to get rid of some of that fluid.
Would they prescribe that if they didn't have hypertension, like they were like maybe borderline, would they?
To get them throughout the full recovery, they do.
Okay.
Okay, edema. Okay, someone from my clinical group, if you don't say something, I'm gonna call up. Okay, when I was with you, when you did your assessments, and I'm watching you, if someone had, a lot of you have 2+ penny edema, some of your patients, how would you describe that to your classmates? Patty,
We push in on skin.
it stays. Memory foam? Oh, fine. Okay, memory foam. Okay, let's stick with that memory foam. How would you know the difference between 2+ and 4+?
4+ is deep,
Deeper indentation.
it takes longer.
Stays longer. You can go out of the room, get supplies, come back, it's still indented. Okay? Okay, if the edema is that much, what could you do independently? Elevate. What's that? You can get an institute TED hose. Elevate unless it's contraindicated. Elevate those.
Would plexi pulses help with?
Yes, because it's gonna set some. Thank you. Set some. What do we put on patients that's besides TEDs that's gonna enhance venous return? Plexi pulses. An STD. Did someone say STD?
I meant, you know what I meant.
Okay.
STD.
So you can have no edema. You can have no edema, a trace, 1+, 2+, 3+, 4+, and it doesn't have to be pitting. It could be, there's an edema called brawny, like it's spelled just like the towel, brawny, where it's so tight it doesn't have anywhere to go. You can go in and it's just hard. Okay. So what we're going to do with this person, anticoagulant therapy, monitor those lab works. Initially it might be PT and then it'd be INR. Until then, you know the side effects of those medications. I will tell you now, the antidote, the med you will give if someone gets too much vitamin K is the antidote for Coumadin. Vitamin K. It does the opposite of what Coumadin does. Heparin, if a person gets too much heparin, the medication is protamine sulfate. You need to remember this. Protamine sulfate is the antidote for heparin. It reverses the effects of heparin.
How do you spell that?
P-R-O-T-A-M-I-N, sulfate.
And the antidote for Coumadin was what?
Vitamin K. Now, I do need to let you know this. When someone's on heparin, the focus of what the physician wants, where you'll hear the word heparinization, you want the control. You'll know what the control is. Your therapy, you know it's therapeutic, and it's 1.5 to 2 times the control. Okay? On what? On your control for heparin. Okay? Coumadin, therapeuticness, 1.5 to 2 times the control. You need to remember.
Start over.
So they're the
Okay.
same?
If you're heparinizing someone, and then you start in with the Coumadin to get them home, relative to the levels of heparin, relative to the levels of Coumadin, which are the norms, that you would see on any lab. You want that person's level on the heparin to be 1.5 to 2 times the norm. On that fluid, you want that level to be question.
So when you say the norm, are you saying like
The norms that you would have for that.
right? But like okay, for heparin, for example, you're saying if it's therapeutic, then your PTT would be 1.5 times the norm, or what?
Oh, if they're on fluid, then you're going to be looking at the PT.
Okay, but when you say the control, that's what you're measuring.
The
1.5 to 2 times.
Yes, when you look at your labs, you'll say,
No,
oh,
your
they're
labs.
really elevated. You want that elevation because it's going to be.
So you want your PTT or your PT-INR to be 1.5 to 2 times the control. Okay.
Both. 1.5 to 2 for both. That is therapeutic that you want because you want where the clots are not forming. Okay.
Coumadin's 1.5, right?
Both. People, B-O-T-H, both. Okay. These people are not wearing medical bracelets. Who's ever there, or the patient themselves will say, I'm on, they'll say Lagerstrom blood thinners. Okay. What medication that we take over the counter every day that you would tell the person to avoid taking? I've heard it.
Aspirin.
Avoid smoking because it's going to cause a constriction that is counter what you want. The blood's going to stay there because of the vasoconstriction. One of that. Venous insufficiency. You know someone has venous insufficiency, and this is not one I'm going to have to test, but basically, you look at the extremities, they're getting the arterial flow, but you see edema because the person's not having the venous return. That's why we use those FCDs and TEDs.
She said that
I'm just gonna go through. When someone says to you someone has a peripheral vascular disease, you want to say, is it arterial or venous? And you know if it's arterial, you go down there and you check the tap refill, you check the kilo pulses, and you can't feel it as well. Some of you had me in clinical, you were saying, oh, this person is a 1+. And I checked it after you went, and it's like a 2+, but that comes with time, assessing the pulsation. This person, there's no edema, but this person might have some arterial problem. What makes you think that? Discoloration. And you check that pulse, and it would be weak. Before you say someone does not have a pulse, what do you need to do? Do a Doppler. See if you hear any. And what does it sound like, a Doppler? A swishing sound. If there's a flow. Okay, I'm just going to go through this one. This is just some varicose veins. I'm not going to test on that. But I want to ask a question. What activities would a person do that would predispose them to varicose veins? I said secretary, nurses, huh?
Crossing their legs.
Mm-hmm.
Crossing your legs,
Oh yeah.
working on your legs, like
Yes.
waitressing.
What gender is high risk for women?
female.
We're not going to do that Trendelenburg test. Varicose veins, back in the day, I mean way back, I'm dating myself, way back. People used to be in the hospitals to get the varicoses removed. Now what they do is laser. Laser therapy. They're in there. Sometimes it's outpatient, a lot of times. They go home. Of course, there's certain parameters that they need to follow, but the varicosities are not what they used to be as far as therapy. And also, the person, even though they have they have the repair of the varicosities, they still need to have rest periods, weight reduction, you know, that type of thing to keep from the occurrence of. Vein stripping, they're not doing as much, they're doing laser. Art. Peripheral arterial disease. What disorder did you have, by the way, no slide, atherosclerosis, that predisposes a person to peripheral arterial disease? Atherosclerosis. What is building up in the artery?
Plaques.
Plaque. What is plaque made of? Cholesterol plaques. And then over time, as that plaque builds up, you have decreased flow, you have decreased perfusion. Thus, this person does not get the oxygenation to extremities. So what would you see on this extremity if they had arterial problem? Besides discoloration?
Maybe hair loss.
Goodness.
Might hairless or decreased hair. You see this guy who's already went through puberty, but he doesn't have any hair on the legs or less, or female too, less hair on extremities.
Where do I sign it?
Someone said they look at it and it may be that it's you're not getting arterial flow, so it might be some degree of cyanosis. Is that pronounced? The patient will say to you, "Oh, as I'm standing, my legs just feel so weak because they're not getting the oxygenation down there." They may have paresthesia, tingling because they're not getting the oxygenation. Individuals can have pain of their extremities while they're at rest because they're not getting the perfusion because of the and her medical term is intermittent claudication. You're not getting blood supply to the musculature. They say that their legs are cramping even though they're at rest, and it sometimes can happen at night while they're at rest. So what the patient is saying to you, only way that I'm able to get rid of this pain is I dangle my leg. I stand up, I dangle, and then gravity is helping you to get that, bring that circulation. So anything that's go to the heart, there may, because of the impeded arterial flow, there may be some discomfort. There's individuals who say that, oh, I even have pain in my back or the gluteal muscles. They won't say gluteal, but they'll say buttocks or whatever. Okay, no hair or loss of, dry scaly skin, thickened toenails, cold, grayish, to truly cyanotic skin, some pallor may occur, and your peripheral pulses are decreased. They may even have ulcerations. Okay, because of the pressure and everything, there may be discrepancy in the BPs. When you hear the term claudication, think of that in relation to atherosclerosis, because there's some degree of perfusion that's or decreased perfusion. That's another picture showing insufficiency. That's an end stage if you do not, if the person does not know. And what disorder?
Diabetic.
You know what I was going to ask already. Because there may be an injury to between the toes at the back of the toes or anywhere on their foot or extremities and they don't know it. Because of the inadequate microcirculation, macrocirculation, this is what people can end up with. It starts in the digits, and physicians will elect to do a metatarsal amputation, or they may do a wedge resection, or the circulation's so bad and they may have to do a below the knee or above the knee amputation if, per se, the person doesn't respond well to a, trying to think of the surgery. They take a, that's what am I thinking about, where they take a saphenous vein, they take the vein, they replace the saphenous vein. Femoral popliteal bypass, where the area impeded blood flow is fixed by, you put either artificial grafting for blood flow, or they take a major blood vessel and just flip it around so that you'll get the blood flow from the patient. He still felt his toes. Oh. Yeah. Okay. This is with this patient, you're going to be checking extremities for color, movement, sensation. Exercise to keep the blood flow going. So why do you know this? What would you tell a patient to do if they have peripheral arterial disease and the weather goes from not warm, and it gradually goes to cold? What would you tell them to do, basically? Warm socks or warm clothing. If they're going to a room where there might be some change in temperature, you want to put on a sweater or something. They need to address the temperature. You want them to avoid putting any direct heat because you are then, you're getting the flow of blood there, but if someone has diabetes or anything, they're not going to sense the intensity of it. Raynaud's. That is a basis of consumption of, you usually see it manifest in the hands. Things that precipitate a problem is change in temperature, stress, and their vasospasm and constriction occurs. It's self-limiting, meaning that it occurs, but if you take away the correlated issue that caused the problem, the vasospasm and vasoconstriction kind of dissipates. The patient may say to you, there's tingling, swelling, and so, that being said, if a patient says to you, oh, my hands are just, there's aching, and you might see some, when you say vasoconstriction, but initially, what would their hands look like? White. The blood's there, like urine, slightly, then it'll get like white, ashen, then hopefully it doesn't get cyannosis. Cyannosis is the late sign. So, what would you tell a patient to do to decrease the intensity of the occurring? Avoid extreme temperatures, cold to relative to cold. Reduce stress as much as possible. Wear gloves. What will you be assessing on this patient in regards to, you know they have the vasoconstriction, but you want to know the degree of perfusion they are having. What do you assess? Cap refill. it is familial. It can be familial. Raynaud's, you want to monitor pulses also besides the capillary field. Here you might have vasodilation that is used when they're in crisis, which is it's going to open up those blood vessels. Avoid cold, precipitating factors like stress and cold. Teach them about the vasodilation they're having. Because if they're taking a systemic, taking it orally during this crisis, what would you tell them to do? What is vasodilation? What might happen to them? They might have orthostatic hypotension if it's one that takes systemic. We're going to take a break a little bit. You can go ahead.
I'll go to Greg.
So we can over this. Okay.
Greg.
Covered it all. Warm, avoid smoking, avoid injuries to fingers and hands. Okay. Burgers, it's just one. Burgers is one where it's an occlusive disease. When you see the word occlusive, just think they're not getting perfusion. The limbs are usually affected. So here again, as a nurse, you're going to be assessing the capillary field, the pulses. That's just a burgers. Also called intermittent claudication. It is a PAD disorder, specific peripheral arterial disorder. You look for any tingling, the paresthesia, any pull. You notice a trend here? You're not getting arterial, you're not, the color of the skin is going to change, the temperature of the skin is going to change, the pulsations will change. And ulcerations can occur when there's the hypoxia that may go to anoxia because of the degree of the flow. You do the same thing. Avoid injury, stop smoking. What has been a trend of a behavioral type thing that they need to do? What is an activity that they would enhance doing? Exercise. Vasodilation, and you said the safety thing is to watch for orthostatic hypotension. Okay. You don't need this one, but it was in there. Let's break.
Oh, so if you don't have it ready by Friday, when you're ready, post it with your like being out there tomorrow.
Mention it in a while. Put it in the journal.
Yeah, just upload it.
I'll show you how to do it.
Okay. So I can find first. And we just have to set them down and upload it.
What's
Oh.
the difference? I'm not I'm learning.
What's
That's okay.
Additive effects.
Okay. Yeah.
So
Yes,
go
if
into
you don't have
CT.
it Friday morning,
and make something better? Make something better. But additive can be the same, but here's
I'll
the
kick
thing.
it.
Let's say you give a patient,
Journal.
I thought additive would be like Tylenol and Coke.
Alright, so
So if I was at my house and I was
create a new journal
okay,
entry.
here's the one down in district.
Just click on that.
Oh my gosh, it just
What
clicked
was
in my
it?
head.
I don't know the.
No, go down.
I know Emerald.
No, go
All right,
browse.
let me just
That's where
explain
you're
one.
gonna upload.
If you gave someone,
Okay. I'm so dumb sometimes.
and they have,
What
what else might could be given in between times to bring down that edema? Well, I'm thinking, anti-inflammatory.
Oh, I come.
Which one do you give it? Additive effect.
So you would just give it together, right?
No.
Oh, because this says additive effects, similar effects taken together.
Yeah. So you give an non-steroidal, anti-inflammatory, and then when they have pain, you might give some kind of.
Alright.
And something to synergize something too, like if you were, we had a question. Someone said something?
Yeah, I had a question. My patient was on Coumadin and aspirin. How does that work?
Because that person was on that, chewable aspirin or one you take daily to keep from any kind of, he was a cardiac patient. And that's to help with decreasing the, platelet aggregation. But also that person was in because they had Coumadin, they needed Coumadin because they needed that, clots forming. They had probably 2 issues going on. What was their medical diagnosis?
Pulmonary embolism.
That's why. Aspirin's not gonna take care of that as readily as giving them Coumadin if the patient still needs the aspirin. But what would you be watching for in that patient?